risk assessments to fulfill the assessment of vulnerable population function within the city, within our OPH plan, which of course is based on the city plan. And so understand your role within the incident management system and how to conduct a health risk assessment within an emergency reception and lodging center and in the home visit setting. And looking at documentation standards for completing the tool and the requirements for personal and professional preparedness. Next slide, please. Next slide. I just wanted to draw your attention to the emergency plan, which you all know intimately, right? If you haven't had a good look at your emergency plan, this is the key page that tells you what public health nurses' major role in the plan is, and that is to conduct health risk assessments. So the function is the assessment of vulnerable populations. OPH has the responsibility within the city plan, but within OPH we've broken it down to HPDP as the lead branch and that because that's our biggest that's our biggest capacity for public health nurses. In a really big event, we may pull in clinical programs. So the function in the plan says we'll conduct health risk assessments with populations who may be at elevated risk as a result of the emergency, and that you would coordinate necessary follow-up actions on identified needs. And that's pretty much wide open, right? Someone who comes to you with an issue, what needs to be done, let's figure out how it's going to be done, and that's just sort of what we do as nurses. There's the guide that guides you in completing that tool is in your package, and an example of the tool is in English and French. But just a note that the French guide has just come back from translation. I have one copy with me. I certainly can email you the French file as well. You can download your own, but if someone wants to take that one copy with you today, you're welcome to take it. And we do have a plan called the Health Emergency Plan for Priority Populations, which helps bring in our network partners as well. And so those are relevant plans that may help you in your role. Paramedics may assist in health risk assessment teams. They're not the lead on health risk assessment. They're the lead on urgent health assessment. They're part of the tool, but if they're not there, we would do the whole thing. So we'll go through that in a little bit more detail. Next slide. So where might you conduct these health risk assessments? So in an ERLC, an emergency reception and lodging center. So in most cases, the nurse would be at the lodging center. ERLC kind of means it could be a reception center where they're just kind of walking through, they're registering, and not a lot of health risk assessment is happening in a reception center. It most likely would happen where people actually going to stay, and there'll be lodging accommodations. Even for like an evacuation center for a fire, they may have set up cots for the night, or prolonged, like an evacuation from the north, where a large group of people is down. They're living in arena accommodations, or they're living in something like the Algonquin residence. Or in Cornwall, they're still in Cornwall, they're still there. 250 people were evacuated to Cornwall over the last month, and they're from Saskatchewan again. And so the Eastern Ontario Health Unit has been sort of caring for all of these folks. Ottawa did not get tapped on the shoulder this time, but you never know when it's going to happen. Cornwall seems to be a favorite place because they have this NavCan facility, and it really does work out well for them there. And so I think that's why they chose that setting. So in home visits, you never know why you might go out, ice storm. Everything that you've mentioned today could happen, and you could be deployed to go door to door. It just depends what's appropriate in the situation. Drinking water advisories are one of the most common door-to-door things right now. Nurses don't tend to get called out that much in these. Public health inspectors have typically been the sort of the main capacity for home visits, but and now we have a whole cadre of volunteers that we can call. So it depends how big it is and how much nursing capacity we need or staffing we need. So it just depends what the situation is, where the incidents happen, and then they just decide their staffing from there. This is new. There's a new plan. Nurses' health risk assessments has been added to a response to an anthrax attack, a terrorism attack with anthrax. And if there is a site where people have been told they cannot leave and they have to wait for test results or they have to be decontaminated because of an exposure, we've added nurses to that plan to say they may be there, they may have a baby, or they have no food, or they don't have their medication that they're due to take, but they're being held at a certain spot. So we said, I think it's important for nurses to be in that plan. So you got added within the last 6 months to that plan, to the city plan. Next. So the purpose of the health risk assessment at this lodging center, most likely, is, or in home, is to find out if that setting will endanger the physical or psychological health of the individual or family being assessed, or if that setting can meet their health needs. So you're using the tool to decide, can they stay there? Or do they need support to stay in that setting? And then if they can't stay there, where should they go? What kind of supports do they need? And then you go from there with either referrals, transfers, get what they need to stay there. So thinking about the health risk assessment that you might do, for example, in a home visit, you usually go there with a purpose. You usually know why you're there. But in a more leisurely home visiting setting, you can do a fairly comprehensive assessment of the whole family situation or their whole physical situation. You might do a very thorough health assessment. In an emergency, it's within the context of the emergency. If there was a flood, okay, now they've got their basement full of mucky sewer water or whatever, and they have to clean out their house. Well, after that flood in Canada, one of the biggest risks was mold. So you're going to ask, does anyone in the house have mold allergies? You know, how are you feeling? And think about the symptoms related to that mold allergy. Or if it was due to a fire, someone asthmatic and have reaction to smoke, and are they not doing well? So you're going to really, really focus in on what the situation is. And so it's within the context of the emergency. It's rapid, it's focused, you don't have to do the whole thing, but you do need to document the ones you didn't assess. So that tool says not assessed, not assessed, not assessed. Oh, this is what I need to focus on today because of this emergency. So it really allows you to focus. You can disregard the rest and just say, I don't need to assess that. And that you're using your nursing judgment and your nursing skill to say, oh, I don't have to ask them every single question on this form. I just need to know what the urgent things are. So the common interventions are education, psychosocial support, referral. So referral, is it urgent? Do they need to go to a paramedic? Psychosocial, you know these situations are very stressful. Someone with a mental health illness, that could really trigger a very serious response. Do they need mental health support? And look around at the services that are there within the ERLC with you, or do they need external support, transferred to a hospital, whatever you need to do. And follow-up, do they need medications? Do they need, what do they need to help them stay there? Do they need assistive devices? And then you have the people that can help you get what you need in that ERLC. Next. Okay. So I'm going to stop here. Jill, just put that up a little bit, the last slide. So this is the end of my introductory section, but I just want to ask if there's any questions on what we discussed so far, so you're sort of clear about what your role is, and how to work within that within the system. Does anyone have anything before we continue? Susan?
Yeah, just wondering what the role of CCAC is. They serve a lot of vulnerable clients who may be on ventilators, bedbound, need lifts, like all of that sort of thing.
The health plan for northern evacuations comes into place. So when you've got pre-planning and you know that people are going to be there for a long term, and you know that where they're coming from, and their health status not being, we usually get tier 1 or tier 2 and on. That plan tells you about how the supports that you have from the LIN. So you have a case manager who would be called in would refer clients that you've identified needs for to the case manager, who would then, do we need a personal services worker? Do we need a big wheelchair for the shower for morbidly obese patients? Do we need anything, any assistive devices?
Yes, I'm actually talking about clients that are already clients of CCAC, so what's their responsibility in an emergency to their clients they already have?
They take response. So if they have their own clients, just like the hospital has clients on home dialysis and that, so they take responsibility.
Okay.
You would assess, say, has this person been around? Can you get in touch with them? If not, then you would try to make those connections for them.
So in a non-northern evacuation situation, in any type of response, the CCAC is an emergency response partner within our network, and we can refer, usually the LIN, the Local Health Integration Network, is an emergency response partner just a phone call away. They're not in the plan as a specific unit there, but they're always involved. And so we would call the LIN to activate the CCAC, and we'd find out if they're already a client of theirs. They would be pulled in very, very quickly, and we're all connected.
Okay. Next. So activation of an emergency reception and lodging center or the home visiting response. So this really means that OPH is going to go into enhanced operations. So there's two ways that this happens. It's either city-led or it's OPH-led for a health emergency. So when it's the city operations center notifies OPH through the duty officer system. Every department has a service duty officer on 24/7. And that person activates our enhanced response. So the very first thing is that OPH assigns an incident manager for our departmental response, and that person, the very first thing they do is assign a team that's going to be deployed either to the shelter or to home visiting or both. And the staff, now if it's a widespread, often when it's a city one, it's much bigger than just one neighborhood with a drinking water advisory or one shelter. Thinking power outage in 2003, the whole city was affected. That was huge. So if it's a big response, we would notify staff through Centrum. Everybody has their contact information up to date, of course. Good. Because every time we use it, we get that, this cell provider is no longer the right one, or get bounce backs. But anyway, so if it's a one-off that you need 3 nurses to go to a shelter, it would probably just be your task force leader would be phoning personally. When it is OPH-led, then we're really into enhanced. Our SDC would be activated, and the incident manager would also have, a liaison information, all the rest of the posts would be filled. Next. So task force leader, so this is the IMS language that I'm using here. So it's not your supervisor. It may very well be a supervisor or a program manager, but it's the health task force leader. And that's the language that everybody else, no us being notified. Now, that's the outside limit. Obviously, we would want this to happen as quickly as possible. And the report to the site incident commander. So if you're talking about a reception center or a lodging center, that the emergency social services that comes under the emergency social services plan, and it's usually somebody from the emergency social services team that becomes the site incident commander. We work with that IMS team to plan what the public health role is going to be in the center. And as Kathy mentioned, this is going to be very dependent. If it's a fire and there's been lots of smoke and trauma and people, it usually happens, I don't know why, but it happens in social housing. So these people don't have resources. They don't have a lot of, they probably came out with a shirt on their backs, no money or anything. So those people are going to stay in that shelter a little bit longer. The Alta Vista Fire, they stayed in there for several hours. Some people even stayed overnight just until they could get them into alternative housing. It's 38 degrees outside and no power in the building. They weren't going to go back anytime soon. So what is how extensive is the public health role going to need to be? And that really depends on the status of the evacuees. You also, at that time, are going to find out who's the team in the shelter. So who are you going to be working with? And I'll get to the reporting mechanism a little bit, but there's a whole bunch, there's social workers, there's Red Cross, there may be paramedics, so there's other people in that team. So you work out who's going to be doing what. You negotiate appropriate space. Now, we used to have a reputation for going off in the basement or somewhere really far away and having our own little spot. The idea is to get where people can see you, where you've got a presence, where you might have an area private that you could do your assessments if you have to, but you're going to be able to be within easy communication with the task force, site incident manager, and other team members, particularly paramedics. It's going to be a sort of a negotiation. If the emergency is big, they won't be there. If it was a plane crashed or the train, if all those people on that via train had been affected and had been evacuated to a center, would have been a little different. But if they're occupied at a site, they're not going to be there. If they're not occupied, they're going to be there because they want to play. And so that's a negotiation between the task force leader and the paramedics as to who does what. You sign in your staff as they arrive, and you brief them. And that briefing needs to include what's the situation, who are your partners in the shelter, what are the objectives right now? Is it going to be to assess everybody because of what they've been through? Is it going to be very limited to just people who come and present with complaints? What exactly are the objectives now? So, their responsibilities, you have to supervise your staff. You keep the OPH operations chief. Now, I talked about the OPH incident manager. That person may also take on the role of the operations chief. If it's only a one-off and you've got 3 staff deployed, you're not going to have 3 people back at OPH working. So you might have, yes.
Can I, just on that point, how about I flip to the next slide to show them sort of that structure? Want me to, there.
So that's the, you are going to be keeping the OPH incident manager and or operator. Now, if there's 2 people, it's the operations chief because you are a part of the operations section. And you would keep them informed. You would let them know about critical incidents that would affect the health or safety of your staff. If you need more staff, warn them that this is going to go on longer than expected. We're going to need another shift. We're cold here. We need help. So they support you. They do not direct you. They do not play. Downtown's always talking about off-site site does not play in the sandbox, but they support you. And so that's why we've got that line there. The information goes out to them, you keep them informed, you ask for things. Okay, back up. So, you have, we'll get to the charting, but forget your regular charting processes and stuff. You document on one form. It's the IMS unit activity log. It's in the bins. You certainly will have a supply there. And it's charting, it's, you chart important, and I'll get to that. But nothing else is needed. You conduct a hot debrief. During H1N1, this became very evident when we did the focus groups afterwards, that when you've been through a harrowing experience, no, not every experience is the same, but if it has been, if you've seen people down and out and distressed, and they've lost everything, and they're, you know, it is emotionally draining. Having a 15-minute, a 10-minute get together with staff together, just to talk about what you've seen, what's happened, any problems you had, frustrations, and get it off your chest so that you're not taking it home and working on it like a bone. So that's what a hot debrief is about, very important. And then later on, within 2 weeks, usually within 1 week, there will be a cold debrief. And this is going to be the corporate debrief form that we use, and that's what we submit to the city about our part in the response, how we found the resources, the support, the situation, what could have been done better, et cetera, et cetera. And you collect all documentation. Now, you know, if you're in a shelter, a long-term lodging center, we have a portable fax machine, we have a portable printer, we have those things to go to the center. You can make a copy of that form. The site incident commander wants a copy of all the activity logs. Yes.
Just to let you know that the bins that we have here are in the Service Command Center, and on that same shelf, sort of the back of the Service Command Center, are those fax machine printer things that Jill's talking about. So you can grab everything. Usually a couple people need to kind of load up their cars with all this stuff, but the emergency resources are there for you.
But that would be for a lodging center, not for a,
Not a
reception center. Okay. So for the foot soldiers, you have to wear the blue OPH vest, because that's going to make you easily identify as a nurse in that shelter. You also need to wear your ID badge. And again, arrive there just as quickly as you can. Normally the task force leader would be the one to get the bin. Somebody who lives next door might be assigned to get the bins instead. The first person, IMS rules, the very first person on site is the lead. You would take over as the task force leader, whether or not you've been assigned that job, because you're it. You become you are the leader, the foot soldiers, and the whole team. And so that you would be the go-to person for health. As soon as somebody comes who's been assigned that role, you transfer the responsibility to them. And you participate in that. When you arrive, you become brief. What are the objectives? Where are we? Who are we working with?
Jill, just one question. So
Yes.
the blue OPH vests,
Yes.
are they housed somewhere?
No, this is what you probably have in your home.
No, I don't have a blue one. I have a black expose one.
Okay, that would be good.
Everybody has fine.
As long as it
Something
says Ottawa
that
Public Health.
identifies-
It's not everybody's.
And there
Yeah.
were little OPH magnets. I don't know whether they're still floating around, how many people got those that you could also put on your vest if you don't have the OPH.
I'm gonna change that, because I didn't know there was black. I thought everybody had a blue.
Yeah, I know, and the other ones have Jerry.
Yeah, that's right.
As long as it's one of the
Yeah,
things that has.
something with public health on it.
So, you because this is a complaint-driven assessment and a situation-driven assessment, you set up shop, the others it's already been negotiated where public health is. So the personal services workers are the greeters at the door, and they might refer somebody who gets off the bus and is going like this, or crying, or emotionally distraught, or coughing, or whatever. They could refer them directly. The Red Cross, who are doing the registrations, they might refer people. They do, you know. So, or the people might self-refer to you. They've been there for a few hours and, I'm time for my medication, I don't have it, better go see the nurse. So that's how you, it's a complaint driven. And so you would conduct your health risk assessment, which we're gonna go into, and you would document what you have assessed and what your findings are on that tool. And then any identified actions you would follow up on. So they need X, Y, and Z, you would follow up to make sure that somebody gets them X, Y, and Z. And you monitor the clients. Now, especially in a reception, in a lodging center where you're there for 2 weeks, it's an ongoing process. They might have been okay when they got there, but they're not very good now, especially when they haven't had a fix in a while and they're starting to show the effects. Report significant issues to the team, the task force leader. Everything goes up. There's not lateral. And you participate in the hot debrief and the closing. So this is the IMS. Now, has everybody taken IMS 100 online?
Hands up if you have taken IMS 100.
Okay, well this is something we're really strongly recommending, because when you're out there with the city, the big thing about IMS is how you relate to each other. In other departments, even people like the UTAWE volunteers and this sort of thing. Everybody.
Isn't it something we have to do?
I think
on a
I was
regular
gonna say,
basis?
isn't it something that we had to do
Yeah.
through last summer?
Yeah.
Yeah, information management system.
It's,
Yeah.
no, it's actually the incident management
yeah.
system. So on your, there's a sheet in your package called Emergency Preparedness and Response Training and Resources. And incident management system is listed on page 2. And the link to Emergency Management Ontario is there. You just go to Emergency Management Ontario, take training, register yourself if you're not already in the system. It's a free online course, and it could take about an hour and a half to 2 hours, depending on what your background and knowledge is. Some people go through it more quickly than others, but if you can take your time. It's kind of based on fire, like a fire situation, but it's the same system.
We had to do it. We all had to do
Yeah,
this.
one
Okay.
thing we had to do.
We all
Is it
had to do
slides
it.
and
We
little
did so many.
videos?
Yes.
It takes per hour?
Slides a little, I don't remember the video part, but things could have changed since I took it. The little
So are
videos.
we
Yeah,
supposed
yeah,
to do this
yeah.
once a year, or what is the expectation?
It's not necessarily to do once a year, no, it's so that you understand the incident management system. If you haven't done it in a while and you feel you need a refresher, that's up to you, but as long as you've done it once and you understand how a system is built, public health uses the system, so when you're in it, it's good to know how it's all set up. So you should at least do it once.
Okay, so this is a diagram of the reporting structure. So when it's a one-off, like it's a drinking water advice, it's something that's just the shelter. It's not a whole citywide operation. EOC might very often, usually, is virtual. So the duty officers are reporting into it by phone. They're having teleconferences once or twice or whatever is necessary for progress.
EOC means City Emergency Operations Center, for those of you who may not know the language.
So this is downtown at City Hall. And so like I said, in a small event, it's virtual. People are, you don't actually go there. The OPH duty officer is the link to that, reporting in. And as I said, we've got the OPH incident manager / operations chief, probably one person, who may or may not be at OPH, but has taken responsibility for our management of our team. And when you go to the site, there's an incident commander that's there, and that's usually emergency social services for our reception and lodging center. I can't think of any instance where it hasn't been. And the health task force leader gets the gives information to OPH, gets support from OPH, supplies, stuff, refreshment, but reports up to the incident commander. And that's the person who gives you your marching orders when you're in the shelter. If there's a conflict, you would report that to your incident manager, and the task force leader would have to resolve that conflict. Health assessments are the function that you're doing, and the health team reports up that way. Yeah. So interoperability. So same situation, and on the left, you've got, now, say it's a lodging center, not just somewhere where people are coming in, getting registered, and you're finding them a place to stay overnight. If you're at a lodging center, you might also have inspectors there as part of the health task force. They have to check out the sewer system, they have to check out the food situation, the toilets, the water safety. So they're still reporting up the same. Your partners in there are reception and registration and first aid, all done by First Red Cross, psychosocial supports, personal service, and the actual functioning and operation of the center is Parks and Rec. So the task force leader, you sign in the staff, could be any number of OPH staff.
So this is home visiting now,
Yeah.
right?
So when what is different about when you're doing a home visit is that the objectives might be different every time. Your objectives are, like Kathy mentioned, it's to see whether the house is safe because of mold, because of sewer stuff. How, was it a finished basement, wasn't it? So that would be your objective. If it is drinking water, it's more information and assessing whether they need bottled water. So all the objectives are very different. Because your team are not working at the site, but they're out there, then you have to document their cell phone numbers, you have to brief them on the objectives, you have to give them safety measures, go in teams of 2, they don't lose sight of each other, that sort of thing. You provide the route assignment and handouts, and all of these are in the home visiting bins. And you supervise staff, so you have them checking in every so often. You want their cell phone number. If the objectives change, we're not giving out bottled water anymore, or we've added another 10 houses to the route or whatever, then you can communicate with each other. And your idea is that you ensure that all staff are safe to complete their route. So when you're out in the community, you wear the OPH safety vest, fluorescent orange with health on the back. If you're going to be knocking on people's doors at 6 o'clock in the morning, in a rural area, you want them to know that you're an official from the city, that you're not Jack the Ripper.
And yes, we will bring those.
Yeah, and they'll be part of the bid when it gets there. You get your route assignment, your map, handouts, and guidelines for doing a safe visit. They're also in your guide. And then you do the same thing. You know what your objectives are. You go home to home. But this time, your objectives might very well be that you're not, it's both the environment and their health. Ice storm, think ice storm, and they've been there for 2 weeks with no power. What are they eating? What medications? Do they have health issues? So though it's different every time. And you document on your responder activity log, again in the bin, and we'll go into that. Oops.
Okay. So, any questions before we move on about that part of the All good? All right. So in your package, you do have this tool, and I'm going to take it out so I can follow along as well. Okay, the Emergency Health Risk Triage Tool. So this tool, as I said a little bit earlier, allows you to quickly document health risk assessment and zero in on the section you need to fill out. I'm not going to go through every line in this tool. As nurses, you're very used to using a variety of tools and documenting what's key. At least document identification of the client that you're assessing, and then zero in on the section that you need in it. It's approved by the College of Nurses of Ontario using the standards that they expect for documentation, such as your signature, and you don't use white out, and you don't cross things out. You have to use normal nursing standards to meet the College of Nurses. Next slide, please. So charted by exception is a term used by the College of Nurses, meaning you're documenting what has been assessed, what's not assessed, and there's a column there. You check off not assessed, and you're documenting significant findings. There's some examples of significant findings here, but this is only the most common. But of course, anything else you would include in the tool as well. Any ongoing assessment, there is some progress notes on the back. If you're watching somebody for a longer term in a lodging center, you have a place to keep your notes. And make sure that if there's a specific situation that you use acronyms together, or you explain what acronyms are, and everybody's documenting the same, so that after the response you know what these terms were.
Okay, so this form is yours for one client? So if we're two
Yes,
nurses or
that's right.
one,
So this is one client, and you can share this tool among your circle of care.
Okay.
So you would keep that for one client, and then within a family, if more than one person within the family needs to be assessed, they all get
There.
a tool.
Okay.
Yeah, it can also be shared with paramedics, because to be honest, the paramedics probably won't use the top of the tool. From what my discussions with paramedics, they have their own documentation system. They may use their own tool. You could say assessed by paramedics. They insist on using their own tool. But if they're there, you would not be doing the urgent risk assessment. Next slide. So confidentiality, of course, you could share within the circle of care, but we still need to follow confidentiality, OPH policies and procedures regarding confidentiality and consent. Certainly if you're going to share this record with someone outside, other than yourself, at least advise the client that you're going to share this record with them.
Sorry, Kathy, will you be clarifying who the circle of care is when you're in a big setting?
Yeah. Well, circle of care in a lodging center would be your emergency social services, a personal services person, or the paramedic there, or there could be a nurse practitioner assisting with a northern evacuation. Could be the CCAC has come in to help provide them some assistive devices, the Red Cross, who has done first aid. So,
I mean, can we assume that everybody that's in that setting is within the circle
Yeah.
of care,
No.
or
The
not?
Parks and Rec would not be.
Okay.
so it's a healthcare team, and certainly,
So not social services?
yeah,
Because
yeah,
they are registered social workers.
yeah.
They're regulated, and they're considered, if they're gonna be doing counseling or psychosocial support, they're part of the circle of
Yeah.
care.
Now,
There's
when
page
that,
24 that
Yeah.
has everybody there,
Yeah.
okay,
Oh, okay.
except for what you said, nurse practitioner, social workers, not here.
okay.
That should be there.
Yeah, good.
That should, it should be there. Certainly, when that task force workforce leader is meeting with the team, and they're deciding how people are gonna work with each other, how the referrals are gonna happen, where you're gonna sit, how you're gonna set up the place. It's sort of that, okay, we are the circle of care, and these are the people that we're gonna work with. It's a little bit of a negotiation every single time, because the
Okay.
responders are different.
So volunteers might not be part of that.
No, I would not have a volunteer chart on this.
Think of a hospital where a patient might go to occupational therapy, they might go to physio, they might go to, anybody who's part of their care.
There's the other, we work a lot with, community health centers. So I don't know, some of them are community, what are they,
Personal service workers.
they're, what do you call?
Health promoter?
Health promoters, so they would count.
I wouldn't say a health promoter would be giving direct client care in most situations, do you think?
But if we're, like, say, if I'm at Morrison Gardens or Foster Farm, there might be a shelter there, if there was a fire in those buildings, or if there was an incident that happened there. I don't know if PQ, I don't know what role they would have, what would they be doing?
Yeah,
Depending
Because they
on
know their community
their
better
position.
than anyone.
yeah.
If they need to know the health findings in order to make a referral or a placement, then it would be reasonable. I think that's the standard you go by. They need to know in order to give care or disposition or whatever, then that's the.
Okay, so you're gonna document any interventions, and then you have your guidelines. Next slide, just a note about the guidelines. In the guidelines, it provides you normal parameters. It doesn't talk about significant findings, examples of significant findings. That's for you as a nurse to know what's not normal. And that's why it's not in the guide, because it's assumed that given the normal guidelines, the normal vital signs, you will be able to determine what is normal. Next, please. Oh, okay. Oh, you did good. So this is the identification section. I'm just gonna scroll right through. Next slide, please. Again, this is a section that paramedics may do it, probably not actually chart on our tool because they have their own charting methods. That's okay. They probably refer over to the nurse if there's nothing urgent, and then let us do the rest of the assessment. So this is for longer term needs. Are they going to be there for a day, 2 days, 2 weeks? They've been in Cornwall for a month. Last year they stayed for a month. And really, it took a lot of staffing capacity, and they ended up calling in Health Canada, the EMAT team, the Emergency Medical Assistance team, to supplement the resources in Cornwall. When you're in a response that long, it's really, really hard on services. And we know, even within our large capacity, what it's like to sort of need assistance and burn out after a long time. Cornwall's even smaller.
Sorry, Kathy, you said this is for long term?
A longer term, just
Because I've been in a shelter where, you know, you come across somebody who's pregnant, who's having contractions or whatever, and
yeah, well,
you would be limited to not filling this out, obviously.
oh,
Like if I'd be a-
longer term means more than just a pass through. So urgent health needs is immediate.
Yeah.
This is
Okay.
now, you know, are they not coping well with the situation for mental health? Are they pregnant and yeah, this isn't.
Well, I've had it immediately there, right?
Immediately, yeah.
I'd be taking her pulse, but she was having contractions,
Right,
so
right.
it's kind of a combination, I guess.
Yeah, this is, that
If
is
they're
more
having
urgent
mental
for
health
sure.
issues there and then,
Right,
you're
right,
not
right,
gonna
right.
wait a couple of days or something to assess that.
It's probably not a fair assessment to say that it's longer term.
Okay.
It's a secondary assessment.
Secondary,
After
okay.
the urgent assessment, and yes, it could be immediate. And it might change that on the slide. You're kind of our pilot test group, because we were gonna have that big session at Ben Franklin with we had like 50 people registered, and city council bumped us. But this is a good kind of test pilot, change a few words, make it a little bit clearer, so this is great. So medications, I think, are the biggest question for nurses in these settings. What can a nurse do? So determine if they need assistance with taking required medication. You can't really give, or you can't administer the medication. But if you could help them open the bottle, you could get them you could get them some water to help them take it. You could remind them that it's due. You could do everything you can to ensure they have their medication, but you just can't give it to them. Right. They have to pour it out of their bottle and do it themselves. So unless there's a medical directive. Now, there are, for example, in the anthrax response in a prophylaxis clinic, there is a directive to dispense doxycycline. And so that's a totally different role. There's a medical directive. You would be there giving them their medication, their supply for however long. Their 60 days is what they need to take doxycycline with an anthrax response. So if they're missing any medications, you could refer to personal services. That's the other unit there. And as Jill was saying, sometimes they can send a fireman up the building to go get whatever they need in that building with the fire. That they're not allowed to go back, and the fireman could. So that's sort of the partners working together to help get what they need. It's way more difficult to get a new prescription for insulin than to just go back into the building and get it out of the fridge. So, do whatever's easiest. Or you may need to make arrangements through their family physician to get a new prescription and then go out and help them buy it, or do whatever it takes to get the medication they need. And certainly if they're diabetic and they need that medication, they're going to need it quickly. So whatever we can do to help them.
Do we have access to petty cash to do those sorts of things through the incident commander?
Well,
yeah, I mean,
yeah.
I'm not going to grab my wallet if I need to get back,
No,
back to the
exactly.
building. Where
Personal services
Yeah.
is connected to the city.
personal services is, okay.
The city finance, they would deal with that.
And
So
they make it as easy as possible?
They would make it as easy as possible.
And then at the NAVCAN
Yeah.
Center, there's actually a community pharmacist who's actually there for the
So-
first part of their stay to get all those prescriptions that they don't have. That you can't very well send somebody back to Attawapiskat to get the prescription.
Yeah. So the services are hopefully there to support you. If the services are not there and there's a unique situation, that's why our OPH managers are there to support you, and they'll make the arrangements, they'll bring people in, they'll get on the phone and say, we got a situation, we need to mobilize something from the health system to support what's going on at the site, and that's what they're doing back at the ranch. We've all had IPAC training, infection prevention and control. And by the way, there are IPAC kits in the bins now, provided by the IPAC team. So if you're noticing everybody's coming down with diarrhea and vomiting, or you're noticing there's an awful lot of respiratory illness going on, you're the one with that vision of really seeing what's going on. Is there something spreading among this group of people? Bring in our team and report it. Make sure that public health, you can send in the inspectors, send in the nurses to do an assessment. What's spreading in this environment?
They've now got chicken pox in 3 shelters in Nepal.
I heard hepatitis was spreading in Nepal as well. It's in these situations, it's horrible because they don't have clean water. They're in crowded conditions. Things will just spread when they're not in their normal environment. So, do what we do, isolate them, put a surgical mask on someone with a respiratory symptoms, do whatever you need to do, get a stool sample or whatever you need to do to figure out what's going on. All right, can they stay here? Yes, no, do they need help to stay here? Do they have to be referred out? Do they have to be referred to the hospital? So that's your determination. What do I do with this client? Is this going to meet the client's needs? Next. Go. kinds of situations did you see in their homes?
I was out in rural, of course, and so there were some cases where we identified stool, dog feces in the house, so that was reported. One woman wouldn't get out of her house wasn't safe, she was burning in a fire chimney that wasn't appropriate, but we couldn't get her to leave. So she was visited on a daily basis. There were other people that should have had some help with a respirator or oxygen, and that wasn't well assessed. There's different things, there's all kinds of crazy things that were happening.
Right.
Yeah, and the road conditions were awful, so we went out with the police after, so
Yeah.
there's different things.
For sure. So that's the kind of thing, it's the home, is it safe for them to stay there? Or is it safe for them to be sent home from the shelter? So sometimes the nurse needs to assist with that determination. And you can look at all of those scenarios on this form. Okay, now what are we gonna do? Are they high, medium, low risk, no risk at all? And there's definitions of what those risk categories are, how fast you need to act, what information, referrals, relocation, and follow-up. So that's your interventions. And progress notes document there. Certainly, there is actually an extra progress notes form in the bin. If you need to document more, you can staple it onto that. So,
Can I just ask a question
Yeah.
about primary assessment? So if the paramedics are doing the assessment, if you're using your forms, you'd say not assessed on all those categories, and would you say referred to EMS?
so they may get, and most likely, they're gonna see them first before
Yeah.
you.
So how do we write it, just so we're all doing the same thing?
Maybe you could just cross it off and say assessed by paramedics.
All right.
Or not assessed, and at the back, assessed by paramedics.
Okay.
So, the IMS documentation. So the unit activity log is filled in by the task force leader. And what we've done is we've altered it a little bit, the standard form, which is heresy, but anyway. In previous, especially those of you who worked on CICL and that, there were all these forms about how many hours you worked, what your cost center was, et cetera, and these all had to be filed by every supervisor for all their staff, had to be filed with our finance department, because we try to get money back from the province if we can. So what we've done is, for the first page of this form, the task force leader has all her staff listed. If it's a home visiting, they've also got what route number they're on and their cell number. And where are they from? Are they from EPI? Are they from clinical programs, sexual health, HPDP? And when that person started and when they ended and how many hours they worked and was it overtime. And so that's your record of the activity that went on during a shift, who was deployed, and how many hours. It's your financial record as well. And at the top, the operational period, that's the period that you're actually working. And so it's not a normal shift maybe, it might be from 10 to 4 or whatever. And the incident name, that's important because at the beginning of every incident, they give it a name, one name. And everybody refers to it as the CICL or whatever. And then on the back, this is the log. So any significant events or a summary of the activities. This is not at 5 o'clock we did this, at 6 o'clock we did this. It's a summary. It's any challenges, problems, anything worthy of reporting that happens during that shift would be reported there by the task force leader and assigned at the bottom. Now the responder activity log, this is where you're going out and you're documenting whether you left the information at the door, if you left it, if you talked to somebody, gave it to them by hand, and any comments. So, woman has a newborn baby and is not breastfeeding, needs bottled water, that sort of thing. That would be something that you would report on the form.
about the home visiting, I'm just gonna come back up. So, you need to do two forms. If you do a health risk assessment, then you'll pull out your tools. So you need to have some tools with you in case a health risk assessment is required in your home visiting. But you also need to do this form as well, which is your documentation of every house that you've been to. So if you encounter an issue in the home and you decide, oh, I need to do a health risk assessment at this home because there's an issue, you'll be doing both forms. Okay, that's it for yours?
Yep.
Okay. Next slide. All right, so we have an activity buried under here. So I'm going to give you each two scenarios. So pick a buddy that you want to work with and work through the two scenarios. So the one person who is the client will get this and sort of figure out who they are and what their problems are. And then the nurse is going to interview them and fill out the triage tool. And then for the second scenario, switch. And you'll each have a little practice filling out the tool. Okay? So, I'll give you...
Is anyone alone?
Scenarios. Or, here, pass those around. Each. There's each.
Doesn't matter what you have. Oh, these are the two different scenarios. Just get ready to run now. So you